Hi, I'm Mercy Miranda. I am a trauma ICU nurse, and I'll be talking about Stevens-Johnson syndrome and toxic epidermal necrolysis. So the disease spectrum involves anywhere from erythema multiforme, which is just a hypersensitivity reaction involving the formation of a patchy rash without necrotic skin involvement or skin detachment, and then it goes all the way to toxic epidermal necrolysis. So the categories include first erythema multiforme, which is just a rash with no skin detachment. Then you go to Stevens-Johnson syndrome, which has less than 10% TBSA skin detachment. Then SJS 10 overlap, which is anywhere from 10 to 30% of TBSA skin detachment. And the last one, the highest of the spectrum, is 10, so toxic epidermal necrolysis, and that's above 30% TBSA skin detachment. All these reactions are all hypersensitivity reactions affecting the skin, ocular, and mucosal membrane as well. So you want to, or the docs want to calculate the mortality risk of each patient. So that's based on the score 10, which involves risk factors including age, associated malignancy, heart rate, BON, the compromised body surface, serum bicarb, and serum glucose. And depending on how many risk factors you have, it raises your mortality rate. Medications are usually the cause of SJS and TENS in approximately 7% of cases. The common medications include anti-gout medications, anticonvulsants, antibiotics, and others including NSAIDs like ibuprofen, cardiac meds like diltiazem, atenolol, and antifungal terbinafine. The diagnosis of SJS and TENS includes both the punch biopsy and the overall presentation of the patient. So it's not just the punch biopsy, it has to include the signs and symptoms of SJS and TENS. So the punch biopsy involves two specimens obtained from separate skin sites with affected and unaffected skin in each sample. It's sent to the dermatopathologist for analysis. These samples need to be transported by hand to the laboratory, so you can't place it in the tube system. The signs and symptoms of SJS and TENS includes first the prodromal state, which includes headaches, fevers, and generalized fatigue. Then you've got redness or erythema, edema, blistering, and then you see the detachment of skin. So you get sheet-like partial thickness skin loss, and then you can see the Nikolsky sign. So the Nikolsky sign you can elicit by gentle lateral pressure on the skin, and the skin should gently come off as you rub it, pretty much. You can also see ulceration in the mucosal membranes, including the oral, ocular, and genital areas. And then you can see in the ocular involvement epithelial defects in the membrane and the cornea. So you can see ejection and scarring and corneal damage as well. The common complications of TENS usually includes multi-system organ involvement, so you can have tracheobronchial skin sloughing, leading to scarring and obstruction, which can lead to respiratory insufficiency and failure. And then you can get sloughing and ulceration of the GI tract, including esophageal stricture and dysphagia. And you can have renal involvement as well, so you can get acute renal dysfunction. The admission protocol includes admitting to the burn surgery service if there's a positive biopsy from an outside hospital or a convincing patient presentation of SJS or TENS. Usually, erythema multiforme doesn't need to be admitted to the burn surgery service. You want to stop the causative agent immediately if it's known. And for the debridement part, it doesn't require surgical debridement. The loose necrotic skin or dead skin can be gently removed in a whirlpool, shower, or the bed. Patients with extensive skin involvement, like in TENS, may benefit from the tank room for debridement on admission. And you want to assess for the positive Nikolsky sign. You want to obtain a Lemon score in non-intubated patients prior to administering any analgesic or sedative medications for the initial debridement. And you want to calculate the TBSA involvement using the London-Browder chart. So That's just, the one in Brado is just to calculate the TBC involvement. You don't want to initiate the American Burn Association Fluid Resuscitation Protocol because it doesn't apply to these kind of patients. Wound care, you want to apply Metholex AG to all open areas except the face, genitalia, and digits. You want to change it every 7 days or as needed if the Metholex is no longer adherent to the skin. And you want to apply vasopressin to all the open areas on the face, genitalia, fingers, and toes. And you want to retract the foreskin and male genitalia for vasopressin application of open areas. For the ocular care, you want to apply the vasopressin ophthalmic ointment to periocular areas as if they're involved. And if actual ocular involvement is suspected, you want to do eye lubricating drops and eye lubricating ointment. And you need to retract the eyes fully for each application. If they're not retracted with each application, the eyelids can get stuck there and the patients can go blind. Oral care, you want to do frequent moisturizer or vasopressin to the lips. You also want to use magic mouthwash for the oral involvement, which is an oral medication that has Benadryl, Maalox, lidocaine, and nystatin, so it promotes healing and comfort for the patient as well. You can use Paradex for oral cleansing as well too. So the treatment for SJS and TENS is usually just supportive care, so wound management. We don't usually use these other therapies that are seen here. So empiric antibiotics have not really been shown to improve survival if they're started on remission. We don't use steroid administration in SJS or TENS patients because they're associated with increased risk of mortality, sepsis, and prolonged hospitalization. Other burn centers have used IVIG, which is intravenous immunoglobulin. That's to promote healing, but it hasn't been shown really to do that. Because of the different formulations that come with each IVIG. Plasmapheresis is thought to remove the causative agents. Cyclosporin may be beneficial in slowing disease progression and improving healing, and there's anti-TNF therapy. TNF alpha serum levels are increased in SJS and TENS, so the thought is to reverse that process with anti-TNF therapy. But again, these aren't evidence-based as of yet.